So I'm going to try to tell you why I have arrived at the conclusion that psychiatry does more harm than good. It's the only specialty in medicine that I know about that does this. And this is because of the huge use of psychiatric drugs. So I'm going to first tell you about how many people are killed by psychiatric drugs. And already this is difficult to find out. And here are some of the major problems in psychiatric randomized trials, that usually patients are already in treatment before they get randomized to a new similar treatment or placebo, sometimes after a washout period, which is too short to avoid cold turkey symptoms in some patients, which is what we call withdrawal symptoms or abstinence symptoms. And what that means is that you harm some patients in the placebo group, and then you conclude that you have a treatment that is better than when you have harmed some patients in the placebo group. But that's not what the drug companies tell you. They tell you we have a good drug that is better than placebo. They forget about the harm they have introduced. This is one of the big biases in psychiatric drug trials. Another big one is that there is no effective blinding in these trials because the drugs have conspicuous side effects, and since the outcomes are subjective, measured on various scales, we know that when the treatments have not been adequately blinded, the assessment of the outcomes will be biased in favor of drug. So this is another very important bias. And then the third bias is that events after the randomized trial is over are ignored. And why is it important to include these events? Because what happens after the randomized phase is over is typically that more adverse events appear in the treatment group than in the placebo group. And why? Because sometimes people stop taking a drug in the active group, so then they can develop withdrawal symptoms. And these symptoms can be sometimes very harmful. One of the worst is akathisia, which is Greek and means I cannot sit still. So people can walk around frantically, and it's a horrible condition which predisposes to both suicide, violence, and in the worst case, homicide. People don't usually realize that it's a side effect. They think that they have gone mad, and therefore they kill themselves because it's unendurable by some of them. It's a very severe adverse effect. There are many other withdrawal effects. They can be psychosis, they can be depression, they can be all sorts of things. And during the randomized trial, the psychiatrists are very keen to keep the patients on the drug or on the placebo. But this is not what happens in clinical practice. When people experience side effects, particularly sexual side effects, which are very common with psychiatric drugs, they might deliberately introduce a pause where they don't take drugs because they want to have sex again. And if they do that, many will develop withdrawal symptoms. They might also forget their pills on a weekend or just for school or university if you study medicine. And drugs with a short half-life, like paroxetine, already if you miss one pill, people can sometimes develop severe abstinence symptoms. Just one single pill. It is like this. This has been documented. So if you add these events after the randomized trial was over, you will more accurately tell people what happens in real life outside randomized trials. And this is quite different. So now you have the three major flaws in psychiatric drug trials, which make it difficult to find out how lethal these drugs are. And then we have the problem that by far most trials are conducted by the drug industry. We know that there are many missing deaths in trial reports. And we also know, as I said, that these abstinence symptoms increases death. This has been documented. And I apologize for, well, I don't need to apologize really, but sometimes people think, oh, the guy just referred to his own book. It's unscientific. It's not. I mean, I have hundreds of references in my book. I can't show all them in a slide. So you have to bear with me. My documentation is in my book, most of it. Because you don't, I'm also a biologist. If you're going to describe how humans developed from fish, you can't just show it on 3 slides with 3 references. I mean, this is hundreds of references. It's the same with psychiatry. It takes many years before you realize the bottom of the problems. Now, missing deaths in published trials has been studied systematically in 142 trials by comparing what was published with trial registers. And what they found was that half of the deaths and half of the suicides, they were simply missing. So therefore, it's impossible for psychiatrists to know how dangerous their drugs are when they read trial reports, when half of the deaths are gone. That's pretty obvious. And you see the drugs were olanzapine, a neuroleptic, and another neuroleptic, and a third one, and a stimulant, and 2 depression pills. It's all over the place like this. Now, one of my colleagues, science journalist Bob Whittaker, has published a very, very interesting book, Mad in America, and another one, Anatomy of an Epidemic. And he has shown that in trials of neuroleptics, where people were randomized to placebo, this cold turkey phenomenon increases death. 1 in every 145 patients died in these trials. None of the deaths were mentioned in the scientific literature, and the Food and Drug Administration didn't even require them to be mentioned. Half of the deaths were suicides. And the suicide rate in the trials was 2 to 5 times higher than usually for patients with schizophrenia. So there you have a documentation that these designs are dangerous and they are actually lethal. And yet they are still used. If I want to find out how dangerous neuroleptics are, I cannot use the trials in schizophrenia because the placebo patients were exposed to cold turkey. So I thought, now I go to the old ones, the demented people, because a good deal of them were likely not already in treatment before they were randomized. So I thought I would get better results by looking at the old people. And there is a meta-analysis of these demented people of 4 neuroleptics. And what you can see, it was published in JAMA. Out of every 100 patients treated, you kill 1 of them, 1% difference. And these are short-term trials, just 2.5 months. Now, you have just learned that half of the deaths are missing. And look how beautiful it is. If you go to the Food and Drug Administration and look at similar trials, then the difference is 2%. That's double as much. And what if we go out in clinical practice? Well, it becomes more uncertain because then it's no longer randomized trials. But let's have a look at it. In a Finnish register study in 70,000 people with dementia, now there were 5 deaths per 100 person years, so that's more than 10 weeks. It's a full year. And of course, the death rate increased with polypharmacy. The more drugs the patients received, the worse it was. So they do kill many people, and yet you can read a lot of reports in the scientific literature, including in the Lancet, by a Finnish guy and other people telling you, oh no, these drugs protect against death. Don't believe them. It's ludicrous. They use unreliable observational studies to get their point across that these drugs save lives. They don't. They kill. It's as simple as that. And you can just look at the randomized trials, and then you will see, yes, they actually kill people. So what about lithium? This is a drug I studied with a Swedish psychiatrist recently. This is a drug that psychiatrists are usually very proud of. There are 24 placebo-controlled trials in mood disorders. It seems to reduce suicide. That's why psychiatrists are proud of this drug. But the trials were very small, and there were only 1 versus 6 suicides in all these 24 trials. And some of these trials, most of them suffered from cold turkey problems, which might induce suicides in the placebo group. And the authors themselves pointed out that only 1 or 2 moderately sized trials with neutral or negative results could materially affect the estimates. Of course, 0 versus 6 is very uncertain. And total death, there seemed to be an effect on total death, but with wide confidence intervals. So what we did was that we looked at trials that did not have cold turkey phenomenon. So we only included trials where patients were not already on lithium. There were only 5 trials that had data on death. And what we found was 2 versus 9. So it seemed that, okay, lithium protects against death. Suicides, 0 versus 3. That's, of course, not statistically significant. But still, our conclusion was that there is no reliable evidence that lithium decreases total mortality or suicides. And why did we conclude that when there was a significant effect on total mortality? Because there is a lot of reporting bias. As you already learned twice now, half of the deaths and suicides are simply missing in psychiatric drug trials. So what can we conclude based on such small numbers? I wouldn't conclude anything for certain based on that. That's the way I was educated. You need to be more careful than that. Then the benzodiazepines. Everybody hates these drugs nowadays, but people should hate depression drugs in the same way. One of my PhD students did a PhD that compared the 2 drug classes, and the abstinence symptoms are very much the same. People get dependent on depression pills like they get dependent on benzodiazepines. They do, and many people have difficulty stopping them again. It's a fact. So people shouldn't be so happy with happy pills. Now, the benzos, I can't really use randomized trials. I didn't find anything, so I used a big UK cohort study, and of course increased doses increased mortality. The drugs doubled the death rate. The excess death rate was 1% per year. Then there is a not so good US cohort study that found that these pills kill a lot of Americans every year. I don't know if this is correct, but that's a huge amount of people. Anyway, well, let me just finish the depression pills. Why do they kill people? Well, one of the mechanisms you will see on the next slide when I look at depression pills, why do they kill people? Well, here is a cohort study, a very good one, again from the UK, of people at least 65, and the excess death rate was about 3% per year. That's very large. And they double the risk of falls and hip fractures in a dose-dependent manner. And when you break your hip, 20% will be dead within the next year. So that's one of the mechanisms. It's very easy for an orthopedic surgeon to repair your hip, but 1/5 of the patients will die anyhow. So I have corresponded with the first author, Copeland, and I felt this was a bit much. But in one of her analyses, the patients were their own control. It is a very good study. it might not be that bad, but they are not innocent, these pills. So, how should I estimate how many people are killed by these drug classes? Well, neuroleptics, 1% death rate, as you saw before. This is conservative, it might be much more. Benzodiazepines, 1%. Depression pills, 3%. I said 2% to be more kind. So these three classes of drugs alone kill 3,700 in Denmark every year. This corresponds to more than 500,000 in the United States and Europe. That's pretty many. And you can see depression pills kill very many because they are so often used. And if you say it's only 1%, it's still very many people. We don't know what the true number is, but I just tried to estimate it. So if this is true, then these drugs are the third leading cause of death after heart disease and cancer. That's very disturbing. And please never forget, psychiatric drugs do not save lives. They take lives. And lithium is the only exception I know about. It might be a good drug, I don't know. We need bigger trials. So, many drugs increase the risk of suicide. Depression pills do. Antiepileptics double the risk of suicide. We don't know really about lithium. Whereas cognitive behavioral therapy actually halves the risk of repeated suicide attempts. My daughter and I did a meta-analysis on this. She studies psychology. So what we found was that people who had been admitted after a suicide attempt, if they get psychotherapy, you halve the risk of a new suicide attempt. This is a dramatic effect. And of course, you could say the same. Do I believe in this effect? Because the trials are pretty small. Here is a big one, 400 suicide attempts. That's a huge trial, and it didn't find much effect. But if you add it up together, you find this with some heterogeneity, I-square 60%, which is moderate heterogeneity between the trials. But if you take this point, it crosses more or less the confidence intervals apart from this one that found a remarkably large effect on suicide attempts. But never mind, as clinicians, we need to act on the best evidence we have. So the best evidence tells us that psychotherapy can prevent suicides, whereas pills increase suicides. So it should not be difficult to realize that psychiatrists need to be educated as good psychotherapists and use as little drugs as at all possible, which means virtually nothing. So I have come to the conclusion that if we removed, I tell you, I have become very unpopular on this. It would be far better for mankind if we removed all psychiatric drugs from the market, because the doctors cannot handle them. It's impossible. So just remove all of them. And we will get patients that will live longer, will have a more normal sex lives, and who would, to a greater degree, come back to work, save their marriages and whatever the problem is. This is what we should be doing, really. And before I go to depression pills, I just want to tell you that every single study that has looked at a country and looked on the prescription of psychiatric pills and the number of people who get disability pension because of psychiatric problems have shown the same. Every single country. When the usage of psychiatric drugs goes up, what happens with people who can't function? It goes up. Now, if these drugs had really been useful, you would have expected the opposite. It just doesn't happen. So there is so much evidence that tells me the same story. You may disagree, but you will have a chance of discussing afterwards. Now, I've chosen depression pills as an example because this is the drug group that I have studied very carefully with my researchers in Copenhagen. They do more harm than good and should not be used at all. That's my bottom line. Not for everyone, not even for your cat or dog. Cats, they become hostile if you give them depression pills. Now, there was this meta-analysis you have heard a lot about in February by Cipriani from Lancet. Great, these drugs do work. Oh, wonderful. But what about The Guardian, the same newspaper 10 years earlier by Irving Kirsch, a psychologist? Oh, they don't work. These pills, Prozac, does not work. So what was the effect estimate? Standardized mean difference, the same. So you can get a newspaper headline saying the opposite things with 10 years difference, and nothing has happened in these 10 years, but this meta-analysis was touted as doctors love this, the final answer about something, about cancer, about diabetes, about everything. They love it, and it's always wrong. Okay? So now, no more discussion about depression pills. They work. No, they don't work. I have a headache, work's been demanding. I got a parking ticket, Prozac, Prozac, Prozac. These drugs are used for virtually everything. Only in half of the cases is there any approved indication for Prozac or the other drugs. So they're used like candy. Now, as I just told you, the standardized mean difference is around 0.3, which is about 2 on the Hamilton Depression Scale that goes up to 52. And a German psychiatrist, Stefan Leucht, has shown that 5 to 6 is the absolute minimum that can be perceived as a change in depression. So what you measure in these biased trials, because you have cold turkey phenomenon, lack of blinding, all these biases, they have been done by the industry. What you measure even in biased trials is less, much less, than what is clinically relevant. And what happens if you put something in the placebo that also gives people side effects, so the trials are better blinded? Atropine. This also gives people dry mouth, constipation, blurred vision, all the rest. Well, then the effect is practically gone. 1 on a Hamilton. So the general observation made by Irving Kirsch is that you can give depressed people anything. As far as it has side effects, the clinician will conclude it works. If it doesn't have side effects, they will say it doesn't work. This is amazing. So this is bias. And what do the patients say? They are much more reluctant towards these drugs than their doctors. Standardized mean difference, 25 patients? No. 29? No. Adults, this was children and adolescents. Adults, 25 patients? No. So just ask the patients, and they won't be happy about these happy pills. Here is a meta-analysis of individual patient data from trials of fluoxetine and venlafaxine. It's highly biased. It's industry-sponsored trials, and the statistician who did this is full of dollars from the drug industry. But it's still interesting. They started being severely depressed, Hamilton score of 21. Then day by day they became better. And one is placebo, the other one is drug. And the difference is not that large. After a month, they are mildly depressed, and they become mildly depressed 1 week later on placebo than on drug. And these are heavily biased trials. So in reality, if there had been a little placebo in these pills, placebo pills, it would have been less, few days. So what can you tell patients? Don't take these drugs. Just be patient. It takes a few days more, then you will be equally fine if you take the drugs. That's pretty convincing to me. then many doctors and patients think they work, but they forget what is the natural cause of the depression. Not course, it should be course. Was ist das in Deutsch? Verlauf. Yes, Verlauf. That's it. I need to change this. So you have just seen what it is. If you don't do anything, people become better. If you do something, people think that's because you did something. That's human nature. And one psychiatrist who came to work with me because he had had enough of his colleagues and all these fake things that went on in his specialty, he said, I can't stand it any longer. Then at the conferences at my department, then a psychiatrist says, yes, and then I started olanzapine in this psychotic patient, and after 2 weeks the patient was better, and then I doubled the dose, and after some other weeks the patient was even better. Now, what is the effect of olanzapine? It's less than what is clinically relevant in severely biased industry-sponsored trials. I won't have time to show you this, but Stefan Leucht has also been useful for this. So, in my view, they shouldn't get olanzapine or any of the other drugs. I know psychiatrists that never use neuroleptics. They talk to people. It's far better. It becomes more likely that they will return to a normal life if you don't snow them under with toxic drugs like neuroleptics and other drugs. Well, but what you should ask about is, do the drugs work on what really matters, saving relationships, getting people back to work? This was never studied in any single depression trial I have seen. And why not? Because these drugs don't help people come back to work and a normal life, therefore it was never studied. Or if it was studied, it was never published. They cause sexual problems in half of those treated who had a normal sex life before they were treated, and this is actually quite much. Here is one study from Spain. 60% of people with a normal sex life, they became sexually disturbed, and a low tolerance for these effects was shown among 40% of these. 60% decreased libido, delayed orgasm or ejaculation, no orgasm, no ejaculation, impotence, decreased lubrication, so it hurts, and some patients yawn during orgasm. That's pretty weird. You can be tired afterwards, but not during climax. I mean, how do you think a conversation would run in the bedroom if you found a new sweetheart? Did you also yawn with other girls? No, never. Why with me? I don't know. So they do strange things to people, these drugs. And persisting sexual disturbances have been documented both in animal studies, we have done one of them, and in human studies. These people can develop permanent, it seems, sexual disturbance. That's very bad. Yes, so it's not only neuroleptics that can cause permanent brain damage. All psychiatric drugs likely can. Now, we have done some systematic reviews based on clinical study reports we have obtained from the UK and European drug regulator. We got hold of 70,000 pages. Do you know how much that is? No. It's 7 meters. If you stack the paper, it's 7 meters. My PhD students, they have read all this. They really deserve a medal for that. They are the first people in human history who ever read all that. I guarantee you, absolutely. Now, and it told us a lot. We have these 2 PhDs, and we had 3 papers in the BMJ, 1 in the Canadian Medical Association Journal, and there's a lot more work to do. So we are still doing it. And I was the one who opened the archives at the European Medicines Agency after having complained to the European Ombudsman. So as soon as we opened the hidden box, I asked for access to depression pill trials. Now, these drugs are not curative. They only treat symptoms. And so a relevant subjective outcome is actually, do people stay on the drug because in trials, because there they weigh benefits versus harms when they decide, should I drop out or should I stay on the drug? And what did we find? 12% more people drop out when they get a drug than when they get a placebo, which means placebo is a better pill, even though they were harmed by cold turkey phenomena. So the real difference between placebo and active drug is bigger than this, I assume. So patients like a placebo more than a drug. That's really interesting. So we have submitted this for publication, but you can also find it on our website because she defended her thesis in April, so the data are up there. And then we looked at quality of life because we felt it must be worse on depression pills than on placebo. It just must. And we could find almost nothing. The reporting of results was virtually non-existent, even in clinical study reports. In 5 trials, it was not even clear which instrument had been used, and there were no results. We could include 15 trials out of all those we had. Some used SF36 and others EQ5D, and some both of them. Complete results, 3 of 8, 4 of 9. And we are not talking about publications. These results must be reported to our authorities. And when we asked the authorities about it, what did they say? Oh, sorry, we don't have them. Why don't they check when they get a registration application from a company? Is everything there? Are all the appendices there? No, they're not, and they don't check it. Look here. Was it? No, it was not here. It was somewhere else. I wrote that we only had all the appendices for 32 of 70 trials. They were not all there for more than half of the trials. They were gone. And what do you think are in these appendices that the regulators have never seen? Quality of life, maybe some deaths, you name it. So it's very likely that depression pills worsen quality of life. Think also of the dropouts and the sexual side effects and all the other side effects. And what about suicides? Well, we also studied that in the clinical study reports because duloxetine had been tried in middle-aged women with urinary incontinence. So we looked at precursor events to suicide and violence defined by the Food and Drug Administration. And what we found was that duloxetine increased activation events, which can develop further into akathisia, this horrible harm in the worst case, emotional disturbance, a factor of 5, discontinuation because of adverse events, factor of 6, core or potential psychotic events, a factor of 2. Many people don't know that psychosis is a side effect of antidepressants. It actually is. So you should remember this. If somebody becomes psychotic on a depression pill, don't rush and prescribe a neuroleptic. Taper off the depression pill and see whether there is a normal person behind that pill. All right? So the FDA did not approve this drug for urinary incontinence, but they did publish some data on 9,000 women in open treatment with duloxetine. 11 had a suicide attempt, and this was an attempt rate that was 2.6 times higher than for other women at a similar age. So indirectly, the FDA has confirmed our findings that these drugs increase the risk of suicide for all people. There is no upper age limit. You have all heard it's only dangerous for children. And many psychiatrists even say it's not dangerous for children. They protect against suicide in children. Why do they say that? Because of poor observational research. The authorities warn about these drugs all over the world. Don't use them for children, or use them cautiously. I mean, how do you use a drug cautiously? Either you use it or you don't. So that's stupid. You shouldn't use it. And yet, professors of psychiatry in all Nordic countries, and I guarantee also many in Germany, they say, no, it's the other way around. They need these drugs. No way. Never give a depression pill to a child. Never. I know so many parents whose children have hanged themselves or shot themselves because of these damned pills. There was nothing wrong with them apart from break up with a girlfriend. I couldn't sleep, and then the doctor prescribed a depression pill for insomnia in a 19-year-old boy, and then he hanged himself 2 weeks later. It is heartbreaking, absolutely heartbreaking. So we also studied suicidality and aggression in children in 70 trials from drug regulators. And there were discrepancies in reporting, which may have led to serious underreporting of these harms. Some outcomes, here it comes, appeared only in individual patient listings in appendices, which we had for only 32, less than half of the trials. And we did not have case report forms for any of the trials. But still, the risk of suicidality and aggression was doubled. This was the first time anyone could show that aggression was doubled in children and adolescents. We could only show it because of these trial reports from EMA. What does that mean? It means perhaps we are approaching an explanation why so many school shooters in America have been on depression pills, because they actually do double aggression. 4 deaths were misreported by the company, in all cases favoring the active drug, of course. A lot of the suicide attempts were coded as something else, emotional lability or worsening depression and so on. One suicide attempt with paracetamol was just coded as elevated liver enzymes. And what about aggression? 5 patients on sertraline: homicidal threat, homicidal ideation, assault, sexual molestation, threat to take a gun to school, there you have it. Paroxetine, damage to property, punching household items, aggressive assault, verbally abusive and aggressive threats. Fluoxetine, belligerence. Akathisia was doubled, like aggression. And we could only identify akathisia if we had access to the verbatim terms, because it was coded as a lot else. And in 3 sertraline trials where we had access to the verbatim and the coded terms, akathisia was called hyperkinesia, which is not as dangerous as akathisia. No cases of akathisia were reported in the paroxetine trial, so maybe GlaxoSmithKline was just worse than other companies in cheating. And akathisia increases the risk of suicide and homicide, as I told you. Now, we also looked at Eli Lilly's website. Adverse events were only shown in most cases if they occurred in, for example, at least 5% of patients. So if 2% become homicidal or suicidal, it's not mentioned. Only 2 of 20 suicide attempts were mentioned, although there were 17 on drug and 3 on placebo. None of 14 suicidal ideation events were mentioned, although there were 14. Aggressive behavior, not so much of many of them mentioned. Only 3 akathisia events, but there were actually 17, 15 versus 2. Okay. Withdrawal symptoms, I told you they were about the same for benzodiazepines as depression pills. And here you can see what happens if patients have been treated with depression pills for a long time, 4 to 24 months, and they are fine, and then you suddenly interrupt the treatment with placebo for 5 to 8 days, then the drugs with a short half-life, a lot of things happen. 1/3 of the patients become irritable with worsened mood, agitated, Hamilton increases of at least 8, which is the difference between mild depression and severe depression. So a lot of this is abstinence depression. It's not a true depression, but doctors usually interpret it as a true depression, and then they say, there you see, you still need the drug. Okay? And the way you differentiate between an abstinence depression and a true depression is give people a full dose. Then they will be fine within a few hours. If it's an abstinence depression, that's like giving an alcohol a bottle of vodka. He'll be fine within 2 hours. It's the same. So it's very easy to differentiate, but doctors, you very often just tell the patients to go on. And what is the result of this? I recently studied Danes on drug who were already on an antipsychotic or an antidepressant in 2006, so they had already been on it before. And then I studied how many of them are still on it or another similar drug every single year in the next 10 years. And here you can see the curves. But what I also did was that I homogenized the curves, because this is number of people. Look what happens if you say 100%. It's virtually identical. I have discovered a new law of nature. These pills are very different. Depression is considered a temporary disorder, schizophrenia a more chronic one, and yet the usage curves are virtually identical. What does that tell you? That the use of psychiatric drugs in psychiatry is not evidence-based. It is about people being afraid of coming off the drugs. It's about a lot of things. It's not evidence-based. Now I have just studied lithium and stimulants used for ADHD, and guess what? Yes. Lithium goes down to about 40%, stimulants a bit more, but they're still similar. It's the law of nature. I'm a little proud of that. That was my last slide. So now you can beat me all you want the next 3/4 of an hour or half an hour or so.
Yes, thank you very much. So, any questions?
You mentioned this possible connection between antidepressant use and gun violence in schools. How did you find that out? Are there data for that?
I did not find it out. I just said that I think that we might, I didn't say that, but I said it somewhat differently. I think that we might be approaching an understanding of some of the school shootings in America, because very many of these young people were on depression pills, and now we have just demonstrated that they double aggression. And I showed you some examples. There was even one who threatened to take a gun to school. So I actually think we're approaching an explanation. And I cannot prove this, but I think we need to pause and think very carefully about this. Is it really a good idea to give young people a drug that double aggression? I don't think so, but I don't have the proof, but I just think it's interesting. That was what I tried to say. Yeah.
I just saw some statistics about the development of depression in Germany, of the diagnosis. So the diagnosis of depression has raised enormously in the last 10 years. And there is one incentive for that. It's that we have a competition of health insurances in Germany. And they get money when they have many ill people insured. So it is called mobilitätsorientierter Strukturaussgleich.
Oh. Yeah.
And one of the indicators for that is that it is adjusted afterwards, because the insurers look which pills they take.
Yeah.
So the pills they take, they get prescribed, is an indicator for the severeness of the illness. If they have lots of pills, they are severely ill.
Oh.
So the insurance company gets more money out of the bigger pot, form, and they are interested for that. And they are direct partners with the pharmaceutical industry, making, making contracts with pharmaceutical industry directly. There are 100 insurances, all state insurances, all after law, and they make rapid contracts. They get good conditions for certain drugs. And so I think this is a very, very, if I listen to what you said, this is such a development we should have somewhere else discussed, not far from here.
Yeah. What do you mean not far from here? The government?
The parliament.
I saw this in Denmark, or, well, no, the parliament, yes. Now, you said a lot of interesting things. First of all, it has been very difficult in the whole world to create the right incentives for doctors. I mean, even in my country, doctors get paid for ordering diagnostic tests, even if they are superfluous. And they get paid by writing a prescription and all that sort of thing. They get paid for making people more ill than they already are. And that's the same all over the world. Actually, doctors should get paid according to if they make people healthy. But of course, that would be very difficult to introduce as a principle, but it's very difficult to create the right incentives. That's the first thing, and you mentioned that. The other thing is that it's an enormous mistake to think that the more psychiatric drugs you take, the more ill you are. Because very often, this polypharmacy arises because of adverse effects. So you take one pill, then you get an adverse effect. Like I said, if you get psychotic or euphoric on a depression pill, then you might end up with lithium or a neuroleptic, and then you have these anti-epileptics and so on. So I once asked a specialist in ADHD, no, he was actually a specialist in bipolar disorder, a professor of psychiatry. I asked him in a meeting in Denmark, how can you know when the side effects of Ritalin and other ADHD drugs are very similar to the symptoms you use when you diagnose bipolar? How can you know it's not only a side effect, but the child has gotten a new diagnosis of bipolar? And you will be astounded by his answer. I can because I'm a psychiatrist. Then I gave up. It's more or less the same symptoms. So I have learned from a very good psychiatrist that if you think your psychiatric patient has an additional diagnosis, the best thing you can do is to taper off slowly the drug that patient is already on, because then the symptoms might disappear, rather than you give the patient 2 or 3 or 4 diagnoses and polypharmacy, which increases the risk of death and also increases the risk that the patient will never come back to a normal life. It's tragic that psychiatric patients who have read books by Bob Whittaker, by Peter Graydon or me, that they have realized, oh, maybe I should come in charge of my own life and not hand it over to the psychiatrist. Maybe I should withdraw my drugs one by one slowly. And then they realize, my goodness, I'm absolutely normal when I get rid of all these drugs. They call themselves psychiatric survivors. I mean, we don't have that in other specialties. If you survive a heart attack, you are grateful, but you don't walk around and call yourself a heart attack survivor and are angry with your cardiologist. You are actually grateful to your cardiologist because you survived. In psychiatry, it's the other way around. I'm sorry if I'm insulting some people here who are psychiatrists, but I'm just trying to be honest to you, and you are welcome to disagree enormously with me, but I'm so grateful for your remarks there. Yeah.
I'm here and I'm not a psychiatrist, I think unfortunately you seem to preach to the converted, and I have to say that I'm also a
and this, unfortunately, because this deprives us, I think, from a discussion.
Yeah.
So my question to you, and it's a tough one, is in terms of limitations. In many papers, we have these sections, limitations of a study. So what would you say are what is the criticism that you normally get? I mean, you must get a lot of criticism.
Oh, yes.
So the ones that make you think in terms of, that's a good one, but I have my argument, otherwise you wouldn't be here. So there will be a lot of silly stuff. But I mean, what do critics say to your really rather damning and very, very profound critique? So what is the critique where you say, well, I have to, this is the one I would, or is there none? I mean, then this would be, I mean, absolutely crazy. But there must be some arguments like, I don't know, you're leaving out this and that evidence or whatever. So is there any criticism that you get that make you think?
Yeah, but it's rare.
What is it?
It's rare. I have to think very carefully to find a good critique that I have learned, that I have learned anything from. But what I can tell you is that I was here in another old auditorium half a year ago, and Konstantin invited me. And there was
the psychiatry.
Pardon?
That was the psychiatry.
Yes, and Tom Shaw was there. He works in another hospital in Berlin, I think. And then there was a guy who worked here that discussed with me, and these discussions were quite interesting. And we continued them on email afterwards. And I tell you, this never happens with psychiatrists because they become angry with me. But these two people actually took up an interesting discussion about lithium, for example, on email. And I can't tell you the details, but I can just tell you that I'm pretty sure that we all learned from this email conversation. So this was a wonderful example, and that made me realize that Charité was a special place. So I'm happy to be back. It is a special place. And we will forget about all these silly remarks that I'm not a clinician, so how can I say what I say? And my argument is, well, I have learned to read, and I have read your papers. So I mean, what's the problem? I don't need to see patients and all these silly things. Yeah.
Thank you so much, Peter. My name is also Peter, and I'm a medical student here. What I found most worrisome in what you just said doesn't even touch upon the psychiatry field of things, but the simple fact that what regulators see in terms of data is so different from what the published literature actually is and what we meta-analyze. And on top of this, when reading through all the data that is actually with regulators, again, it's different than what they would say when we ask them.
Yeah.
And I wonder, is this the case in other areas too? Is this the same for, let's say, cardiology and trials in cardiology? And is it the same for other medical fields? And if so, what can we do to get this data?
Now I told you, my oldest daughter studies psychology. And psychologists always say, what do you think? Okay? What do you think?
I think we should talk to our regulators a bit more.
Well, but when you ask me, is it the same in other specialties? Then just think about follow the money. There is a lot of money to be earned by cheating. And the drug industry is the most criminal of all industries. It even beats oil and these other bad industries. So there you have the answer. You would expect to find similar problems in other areas. And some of my researchers and I have been studying clinical study reports of the HPV vaccines, for example, from EMA. And everybody says there are no serious harms. Well, then why do some young girls suddenly faint? and get nervous pain and these things. Oh no, it's not really, it doesn't really exist. That's not because of the vaccine. But by looking at these study reports, even though they did not use placebo, so they destroyed all their trials. They had an active vaccine in the placebo group that can also be harmful, like hepatitis. Or they used a vaccine adjuvant that can also be harmful. And yet, we did find a signal. We did find more neurological harms with the HPV vaccines than the active control groups. So we have submitted this for publication. So there you have another example where the whole world is saying, oh no, don't worry, these are wonderful vaccines. There are people who are seriously harmed.
And what do you think is the future of meta-analysis then? I'd be curious to hear your ideas on how to improve the way we do it now.
Well, I'm so radical that I was just kicked out of Cochrane, my own organization that I created 25 years ago. I was one of the founders of Cochrane. And our criticism of the Cochrane HPV vaccine review was a major factor why I was kicked out. They didn't like us criticizing that in a scientific journal. They deny it, of course, but I can prove that this played a major role. So I'm currently writing a book about this. It will be quite juicy. And I shall survive, even if I get fired back home from my hospital. But Cochrane has shot itself in the foot by kicking me out. They shouldn't have done that. So now you've heard a little about my organization. It has a very bad leadership right now.
Ich würde gerne auf Deutsch kurz was dazu sagen, für alle, die zu spät gekommen sind. Es gibt draußen ein Flugblatt, in dem ein kurzer Kommentar zu der Aufsperrung, zur Entlassung von Gøtzsche und Cochrane zu lesen ist. Wer es interessiert, der kann es nachlesen. Da geht es um sein System, was er heute auch dargestellt hat, dass in Studien verfälscht werden, dass bestimmte Angaben nicht drinstehen, dass Studien nicht veröffentlicht werden und so. Geht es also um eine grundsätzliche wissenschaftliche Frage im Umgang mit Studien. Kann man draußen auf beiden Seiten sich vom Tisch nehmen, wenn man es noch nicht hat.
Oh, can you translate that?
Talk about the flyer.
It's a flyer.
Oh, yeah. Oh.
Thank you, first of all, for this very nice talk and very interesting data you were presenting. I work actually in the psychiatry department. I was so unlucky to not be there when you were...
Unmuted, now somebody slammed the door. What did you say?
I was not able to attend the lecture when you were at our department in the psychiatry in Mitte. And I'm happy to learn a lot more about your opinion on the treatment, and particularly what is your opinion on the evidence for neuroleptics in acutely psychotic status in the acute ward? Do you know that there is good data on it?
Yeah. Oh, yeah. I write about it in my psychiatry book that you can also get in German. Tödliche Psychiatry or something like that. I can tell you several things. Some outstandingly good psychiatrists I know in several countries never use neuroleptics. Never. And they have good results. And I can give you one example, the open dialogue model from Lapland in Finland. I have a slide where around 70 people with schizophrenia from Stockholm were compared with 70 people with schizophrenia from Lapland. First episode schizophrenia, I'm pretty sure it was. And then in Stockholm they used a lot of neuroleptics in virtually everyone. In Lapland they have this acute team that rushes out that consists of a psychiatrist, a psychologist, the family, friends and so on. A social group that takes care of the person. And they don't use neuroleptics very much. And after 5 years, the results are so much better in Lapland than in Stockholm that even though it was not a randomized trial, it's very, very convincing.
that neuroleptics prevent people from coming back to a normal life. That is very clear. There are many other studies that have shown this, which I also comment upon in my book. And there is an Icelandic psychiatrist who doesn't want me to tell the world who he is. He is very famous in Iceland. He just told me this. And I describe his story in my book. That when he was a psychiatrist in London, he and the other chief physician decided that they wouldn't use neuroleptics for acute psychosis. So the first 2 weeks they didn't do anything. They just talked to the patient. Then after 2 weeks the patient could have some, but in such a small dose that they considered it almost homeopathic. I mean, it was very small. So what they thought was that it had nothing to do with the neuroleptic, that some people then said, okay, give me that after 2 weeks. But it was their human interaction with the patients. They took them seriously. They talked to them, although they might tell you all sorts of funny things. They took them seriously. And that's another very interesting study. And then we have the randomized trials. There are 14 trials that have compared benzodiazepines with neuroleptics for acute psychosis, and they are not very good, but there is a Cochrane review on that. But what they tell us is that actually you get sedated better on benzodiazepines than on neuroleptics. And when I lecture for patients and relatives and ask them, what about your next psychosis? If you could choose yourself, would you choose a benzo or a neuroleptic? I haven't heard a single one who said, I want a neuroleptic. These are horrible drugs. People would rather like a benzo. So you have a lot of reform work to do in psychiatry. Good luck.
Hello. I apologize for not having read your book either, but I have a question about psychostimulants in children, like Ritalin in ADHD, which is prescribed super widely, and I think there is the best evidence for it for drugs in children at least.
Did you ask about the evidence?
Well, at least I know. Well, I hope you can tell me about it. I hope you can tell me a bit about it.
I can't hear that.
Could you tell me what you can, what you think about prescribing Ritalin in children?
Yes. Don't do it. Should I say a little more? Okay. These trials, even with psychiatric measures, are incredibly biased. They're absolutely horrible. We are studying these trials. We are doing a Cochrane review on Ritalin, my researchers and I. And some of our colleagues next door have published a huge Cochrane review also on these drugs. They didn't find a single trial that was, what do they call it? Oh, they found that all trials were of low quality. Every one of them, more than 100. And even if you look at these low quality trials, then what you get out of them is that the acute effect of these drugs is, as you know, that some children sit more still in school, but they all also become more neurotic, as we called it in the old days, obsessive compulsive, disorder-like. They become more attentive in a way that is not very useful. They become less curious, and curiosity is very important for developing a child's brain. They become more socially isolated, and after a relatively short time, you can't see any positive effects of these drugs. Then you only have pretty negative effects. And you can't see any effect on prevention of criminality, prevention of drug abuse, and all these things. On the contrary, if anything, these drugs seem to increase the risk that the children end up this way. Then you have the long-term studies that show that if you take your drug year in and year out, compared to children that take very little of their drug, then after a number of years, there is a difference of 5 centimeters in height. 5 centimeters. And they do a lot else damage to these children. So to me, I don't have time to go into all the details, but my conclusion is they should not be used at all. They should be taken off the market. They are nothing but amphetamine on prescription. They are amphetamine-like drugs. Take them off the market. They are harmful. They are definitely harmful. And to come back to your point about why are there so many depression diagnoses, that's, you know the answer. That's because the criteria for getting a depression diagnosis has gone down and down and down by psychiatrists who were on drug industry payroll. So it takes almost nothing to get a depression diagnosis nowadays. I have talked to Danish psychiatrists about this, and they tell me that there are not more seriously depressed patients than 30 years ago. It's only all these mild cases that are not really depressed patients. It's just a foolish way of making the diagnosis. So then I also remember to address that one. Yeah.
Hello, my name is Sarah. First of all, thank you a lot for that super interesting talk you gave, and also like the time you're spending on let's say supporting real evidence-based medicine. My question probably goes a little in the direction of what Peter asked earlier, and that is, you already said that the Cochrane kicked you out, which is obviously not the way to go to get ahead of this problem, let's call it, that is obviously even so much bigger than just psychiatry, but we are assuming is probably prevalent in all of medical research. Is there any good example you would say of, on a more political scale, that you would say of, that might get us somewhere in regards of getting ahead of this problem? Let it be like institutional, as in a government setting, or non-governmental, where you would say this seems to be a way that might work to actually control the data that we're getting, and that the research is actually benefiting medicine and not just like the big pharma.
Oh yeah,
Thank you.
I try to work a lot with these issues, and I have been active in the European Parliament, influencing the law together with politicians there, so we get much more access to data than we got before. And there are many ways you could improve on this. For example, I know Beate Wieseler from IQWiC in Germany, in Köln, and when they were to assess reboxetine from Pfizer, which is the depression pill, they asked Pfizer for all the trials, not just the 2 ones they had published, and Pfizer wouldn't give them all the trials. And then they said, okay, then we will write a recommendation that your drug will not be reimbursed because we haven't seen the data. So they put pressure on Pfizer. So little after little, Pfizer was forced to give them also 6 unpublished trials. And when they analyzed all 8 trials, there was no effect, which is remarkable given all the biases I've told you about. So this drug is even worse than the other ones. These are the kind of measures we should use, and Cochrane has failed totally on this. Because when Cochrane people do Cochrane reviews on drugs, and they use published trial reports, they know that they are being fooled all the time. So Cochrane should start telling drug companies, if you don't give us the clinical study reports of all your trials, then we will publish a Cochrane review where we will say, we didn't do a review because we didn't get the data. So therefore, dear doctors, don't use this drug. I would love to see Cochrane reviews like that. they would take up less than a page. So we have the possibility of doing something. We can do a lot else.
I was a little bit surprised when you said at the beginning of your talk that you don't really know another specialty like psychiatry. I can give you other examples. Another very prominent example is the opioid crisis.
Yes.
Pain treatment does exactly the same thing, and you can see it on TV every day.
Yeah, I agree with you, but pain is not a medical specialty, really.
Oh.
No, you know, it's people who are anesthesiologists and other people, sometimes specialists in internal medicine, maybe in your country, I don't know. But yeah, but pain, don't you agree that pain is not a medical specialty? I mean, it goes all over the place. You may be a specialist in treating pain, but that's a different thing. But I agree, of course, with you that the treatment of pain is actually quite funny, because I published a new book a half a year ago that has also come out in German, where it's called Gute Pille, Schlechte Pille, I think you just showed me. I have 2 chapters there that are interesting, because one I call emotional pain, where I describe that psychiatry is about something else than pills. And then I have another chapter that you might guess is called physical pain. So I have actually written about these things that you are interested in. And also the fact that some pain specialists, when they titrate all these various drugs, they have antiepileptics, antidepressants, opioids, whatever they have, in many cases, I hope you agree with me, they should better be good psychologists and tell their patients that pain will never go away. You need to find a way to accept it and live with it. Do you agree?
Yeah. Okay.
I'm happy. Yeah, we all have pain. I have pain in my knee, in my back.
I mean, this is even a more prominent example than psychiatry, because you can see this every day on TV.
Yeah. But psychiatry is the hidden disaster. It's not so much on TV. The things I have told you here, you don't see that much on TV. It's kind of, we don't talk about this. We leave it to the psychiatrist. Oh my goodness, no, that's too dangerous. Don't leave it to them.
I still had a question on, you partially answered it on, so studies and trials need to be funded, right? And so usually the results go in favor of who funded it. And do you have any ideas on systems we can develop to avoid that so that it's less biased?
Avoid trials funded by industry?
But generally, like, who has the money and like where does it flow? And so how do you, like, funding the trials?
Trials?
Trials.
Yeah.
Yeah.
Yeah, of course. I have written a paper about that a year ago, I think, called Patients, Not Patents, where I argue that all patents in healthcare should stop because they are harmful. They are very harmful. And also I write in that paper, of course, that the drug industry should not be allowed to be its own judge. I mean, it's absolutely ludicrous if I am accused in a court trial and I come to the judge with my 7 meters of documentation and say, Your Honor, I have produced all the evidence myself in my case, so please read all these 7 meters and tell me whether I'm guilty or not. I mean, he would have a big laughter, wouldn't he, or she? But that's how we deal with drugs. Even though our drugs are the 3rd leading cause of death, they actually are. Several studies have shown that. Maybe not necessarily psychiatric drugs, but our drugs in general are the 3rd leading cause of death. So we have a system that is totally dysfunctional and kills a lot of people. So we should not allow the industry to do its own trials. In a transition period, the industry could still fund the trials, but then they should just hand over the money and have absolutely nothing to do with the trials. They should be done by independent doctors. The data analysis should be done blindly. That's how I did randomized trials. I didn't know what was A and B, so I produced 2 different manuscripts. And all my co-authors, they become very quiet when they don't know what A and B is. As soon as they know what A and B is, and if they don't like the result, then they say, despite the randomization, there were more serious cases of tuberculosis in one group than in the other. You need to adjust for that. And then they know, of course, that it will benefit their hobby horse if I adjust for that. So I introduced this principle of blinded data analysis many years ago. Now, this we could do in a transition period, but basically, most breakthroughs in drug treatment come from publicly funded laboratories, not from the drug industry. They don't do much research. Therefore, we should actually not have capitalistic drug companies. Drug development and research should be a public enterprise for the public good, and then we could price the drugs so that we could afford to buy them, even in Africa and India. It would be a gorgeous new world. That's where we need to go.
I have one question. Now we found out that all these drugs are very dangerous, and you say we should take them off the market. But what is the solution? Because there are still people suffering from these diseases. Are those drugs just not good enough? Or do you think we don't need these drugs at all? Are all the patients, will they be happy without drugs? Or, do we need better drugs or no drugs at all for psychotic disease?
Well, first of all, the usage of psychiatric drugs is not evidence-based. I showed you these curves. It is controlled by the drug industry and corrupt psychiatrists that get a lot of money from the drug industry, particularly in the United States. It is very tightly controlled by the drug industry. So since we cannot handle these drugs in a way that they do more good than harm, my first conclusion is take them all off the market. Then we would have patients that would be much better off than today. Much, much better. And then you say, couldn't we develop better drugs? No. We have done a lot of research in psychiatry for so many years, and what do we have? Harmful drugs. So why go on researching that? Why not become much better at the human side of psychiatry? Psychotherapy, empathy, loving care, all the rest of it. It means so much for people to be loved and respected and understood, even though they say I'm Jesus or Napoleon or whatever. It's so important. It's not a drug thing. Opium wasn't good. It's a very old thing. Alcohol isn't a good way to deal with psychiatric problems. We have had alcohol for thousands of years. Even apes sometimes eat fruit and get drunk because there's alcohol in them. That's not the way forward. Forget it. I can't see any future in this. We have tried for so many years, and what do we have? This disaster. I'm sorry, but that is, you can disagree with me. I'm just telling you what my conclusion is. And to give you one example, a personal one, when I did my doctoral thesis, I worked day and night. And I had a full-time job, and I did my thesis at the same time. So what did I do when I worked hard till midnight? Do you think I could just lie down and sleep? Of course I couldn't. It was horrible. So what did I do? I took a benzodiazepine when I had been awake for too long. And what was the result of that? Could I do reasonable studies the next morning? No. I had a hangover. It was horrible. So I tried these benzos for a while, And then I realized, no way, never again. So what do I do now when I have problems with Cochrane and they kick me out and I have difficulties sleeping and I'm maybe filing lawsuits and all that sort of thing? It really occupies you. So you have difficulty sleeping. You might wake up at 2 o'clock at night. What do? I use a very common psychological trick. I tell myself, stop thinking. Think that you are becoming heavy in your face. Everything is going down. Your eyelids are going down, your mouth. You breathe deeply, long, long. And you watch your breathing, and I even start counting my breath. 1, 2, 3. And when I'm very disturbed, I don't get longer than to 8 or 9. And then suddenly my mind wanders away, and then I punish myself and said, stupid, you start from 1 again. 1, I just want to sleep, I'm tired. 1, 2, and then I start all over again. And then I reach 12. And then I lie there for a full hour, maybe. But sooner or later I fall asleep. And I am fine next day. That's my point. Even though it was difficult. No, this kind of self-suggestion. I once went to a course where I learned this, and I wanted to demonstrate it to a girlfriend I had, who had difficulty sleeping. So we lied down in my bed, and then I told her all this. Just feel that your head is becoming heavy, and I went through all that, and before she fell asleep, I fell asleep while I was talking. I was so good at it, so I fell asleep. And then there is the other trick. Read a book. If you can't sleep, get the light on, start reading about world history, ancient Rome, the explorers, Magellan and all that. And you know, after some pages, oh my God, I'll turn off the light here. It's a fantastic way of falling asleep, isn't it? Yeah, you know the trick. No drugs, please. Well, it was pretty personal, but it's kind of funny. So I never came up, I have this idea that I go up to 30. I have never succeeded to count my breath up to 30. Before I get there, my mind starts wandering, or I fall asleep. I just can't get to 30. So there is something in it.
Thanks so much. I have kind of a follow-up question to that. Do you think that what are, in your opinion, drugs and conditions where we actually have psychiatric drugs that work? Are there such conditions and such drugs, in your opinion? And the second question, kind of follow-up to this discussion is, so if in most cases psychiatric patients get better if they do despite of the drugs than because of the drugs, why don't we have more developed interventions that are based on other approaches, and what would these approaches be except self-suggestion and meditation?
I don't know if it is my age, but I have some problems hearing the questions. Can somebody tell me what you said?
Okay,
no, not the same. One of you.
First question, very simply. Are there conditions and drugs that, in your opinion, work?
That what?
That do work.
Oh, well, okay, yeah. Of course. But I don't need to tell you. I'm at a hospital here, am I not? Or a university. You know a lot of good drugs. Some of them have saved my life. Antibiotics. I don't need to tell you that. I'm here to tell you that since our drugs kill so many people, what can you do to kill fewer people?
No, but in psychiatry specifically. Are there in psychiatry, when talking about psychiatry, are in psychiatry drugs existing for conditions that do work, in your opinion?
Oh, that was a tough one. When you say do work, it raises a lot of questions. work for what? Not on some funny subjective scale that is influenced by lack of bias, but on things that really matters. Death, suicides, getting back to work, to school, all these sort of things. Having a sex life, being happy. Yeah, that's difficult to measure, so that wasn't a good one. And then you have all the harms. So it's always a question of weighing benefits and harms. So if you do that, I don't really know, apart from you can be so horribly disturbed by something that you would like to be calmed down, okay? And in that case, a benzodiazepine might be a good thing to calm you down. If you haven't slept for 4 or 5 days, you might become psychotic and start getting hallucinations, right? So it could even have a preventative effect if you took a benzo to get some sleep before you do become psychotic because you haven't slept for 5 days. So I'm not saying that psychiatric drugs can never be helpful. I'm not as radical as that. What I'm saying is, take them off the market since doctors can't use them. That I'm very clear about. But it's not the same as saying that they might not sometimes, rarely, in acute situations, have a worthwhile effect. But not chronically, definitely not. And this is the big mistake we do. I hope that responded to your question.
Short questions. Thank you very much for the talk. I would say that making drug research a state enterprise is a good idea. The world is not ready for it at the moment, I would say.
No.
So let's think of practical approaches. Maya Wilson at John Hopkins, for example, they and others proposed to use multiple sources when analyzing evidence in meta-analysis. What is your current proposition to Cochrane and others for the future to conduct systematic reviews in meta-analysis?
What was it they were doing at Johns Hopkins?
Maya Wilson and
Pardon?
Doshi. Maya Wilson and his group,
Yeah.
and Peter Doshi, they were proposing to use multiple data sources when obtaining and finding studies and information.
Okay.
Slides,
Okay.
do meta-analysis. They did a couple of papers on that.
Yeah.
So what do you propose from now?
Well,
how Cochrane should proceed in the future doing meta-analysis and systematic reviews?
Well, I know Peter Doshi, and now I have also published with him recently.
I did as well.
What?
I did as well.
You did as well, yes, yes. Yeah. It's a good idea. In all science, the fundamental thing is that you are open. That if you suddenly find something you didn't expect, then it's human nature to overlook it. But if you're a good scientist, you will say, oh, that's strange. I didn't plan for that in my protocol. But maybe it could be interesting to study this a bit further, maybe in another study. So you have to be very open to be a good scientist. People sometimes forget that in these times with protocols and all that sort of thing. So Peter's idea about different types of evidence, I agree with that. And I have made Cochrane reviews that also took into account other evidence. For example, many years ago we did a review of low-dose corticosteroids for rheumatoid arthritis, just 5 milligrams of prednisolone or something like that. And then, of course, we also wanted to know something about what are the long-term harms of giving a little dose of prednisolone for many years. And in order to do that, we included comparative cohort studies where some people have gotten a low dose, maybe not for rheumatoid arthritis, but for kidney diseases or something else, and then there was a control group, so we could have some idea what happens with the skeleton and other things in the long run. So there is, one of our Cochrane reviews have these data in it, but not formally as part of the review, I think. It's in the discussion. But you could make it part of the review and put it into methods. That's also possible in Cochrane. And sometimes patients' perspectives are enormously useful. But then it gets much more difficult to find out, are these reliable or not? But sometimes when you analyze reports to the health authorities, then you realize that, my goodness, there is a signal here. For example, people on depression pills, when they become abstinent, they describe that it's like having an electric current through the brain, zaps. I mean, that's a very weird side effect, but when more people say the same, you start believing, oh my God, here is a very curious side effect I've never heard about before. So this is again about being open and not just saying, oh, these are anecdotes, and you know. So yeah, I agree. Yeah.